What are the health effects of disclosure? As shown in the table on page 117 of your text, a number of studies show the link between expressive writing and improvements in health. First, we need to distinguish between emotional expression and emotional disclosure. Emotional expression is the venting of feelings, often non-verbally through crying, laughter, or stomping feet. Emotional disclosure requires translation of feelings into language and is therefore more self-reflective. It may not be emotional expression itself that is helpful, but rather the cognitive integration that improves understanding. Both writing and speaking about into a recorder or to a therapist produce greater improvements in health than writing about superficial topics, what you did that day, etc. Note, expressive writing is different from seeking support from friends or other interactions because writing eliminates the possibility of punishment. Early studies found links between expression of emotion, disclosure, and subsequent health, and health risks of not talking. However, these studies were correlational. To isolate some of the causal mechanisms, more recent studies were conducted whereby participants were either encouraged to disclose or not disclose, control, superficial condition, about emotional experiences. Both groups are asked to write about assigned topics for 3 to 5 consecutive days for 15 to 30 minutes each day. Those in the control group were asked to write about how they use their time, etc. Procedural differences that affect the disclosure effects. Writing versus talking. Both talking and writing about emotional experiences are superior in terms of biological, cognitive, and mood effects to writing about superficial topics. Length of days of writing. Different experiments have asked participants to write from 1 to 5 days, ranging from consecutive days to sessions separated by a week, ranging from 15 to 30 minutes for each writing session. The more days over which the experiment lapses, the stronger the effects. Individual differences. Generally, no consistent personality differences have distinguished who benefits from writing versus who does not. Exceptions are those high on hostility benefited more from writing than those low. Meta-analysis found that males benefit more than females, although both benefit overall. Educational, linguistic, or cultural effects. Within the U.S., writing about trauma benefits professionals who have lost their jobs at rates comparable to maximum security prisoners with 6th grade educations. Also, there are no differences among those from different countries who speak various languages. Writing in clinical samples. Writing may not work by itself in samples that may have disordered cognitive processing or severe depression. Example: Gridron and colleagues in 1996 found that in a group of 14 PTSD patients, the half assigned to write and orally expand about their trauma got worse than controls, perhaps because they need writing in conjunction with cognitive and/or coping skills training. Another study found that those in prison for sexual offenses benefited from writing, but those in prison for other reasons did not benefit. Overall, beneficial effects are generalizable across a variety of demographic variables. Expressive writing leads to improvements in patients with asthma and rheumatoid arthritis. These diseases were chosen because they're relatively common, affect daily life, and cause economic and personal burden. These health outcomes are more direct than in other studies, using health center visits, because they are tied to disease status. 47% of experimental patients had clinically relevant improvement, whereas only 24% of control patients had improvement. Why does disclosure work? Cognitive and linguistic changes associated with writing. An increase in both causal and insight words over the course of writing is strongly associated with improved health. It shows meaning making. Traumatic memory research. Traumatic memories are more disorganized than other memories. Therefore, the ability to make meaning, integrate, should help them cope. Writing may help assimilate the memories from sensory affective components to an organized linguistic format. Interestingly, more beneficial results are observed in groups who were instructed to write a narrative telling a story about the event rather than merely listing thoughts, feelings, physical sensations in a fragmented format. This shows the importance of making meaning. Heart disease is the leading cause of death, not only in the US but worldwide. It accounts for more than 1 of every 5 deaths. Like cancer, it is rare prior to age 40, but incidence rises sharply in middle age. One of the most striking aspects of cardiovascular disease is that 32% of deaths that occur each year are premature deaths, occurring well before the age of 75. Smoking is the number 1 behavioral risk for CVD. Rates are highest in countries such as Denmark, where a high-fat diet is common, and in countries such as Russia that have high rates of smoking. The Framingham Heart Study was the first to establish a relation between the levels of cholesterol and high blood pressure and their effect on heart disease risk. The children and grandchildren of the original cohort still participate today. Included within this category are heart disease, such as myocardial infarction, and disorder of the circulatory system, such as stroke. 40% of deaths in the U.S. are attributable to CVD. There was a sharp increase in CVD deaths from the 1920s to the 1960s, followed by a decline that continues today. There was also a decline in occurrence of a first heart attack. Terms to keep straight: atherosclerosis, formation of plaque within the arteries. The linings of arteries thicken as deposits of macrophages stuffed with LDL, abnormal cells, and other cellular debris accumulate over arterial lesions. The passageway becomes narrowed, and flow of blood through coronary arteries is impeded. Arteriosclerosis, loss of elasticity or hardening of the arteries. Coronary artery disease, also known as coronary heart disease, arises as a result of atherosclerosis and arteriosclerosis. It can be developing while a person is unaware of its progress. For 55% of people with this, a heart attack is the first symptom. Ischemia is the restriction of blood flow and can cause angina pectoris, restriction of blood flow to myocardium. Symptoms include crushing pain in the chest and difficulty breathing. If there is a complete blockage of either coronary artery, the result is death of myocardial heart muscle tissue and infarction. Myocardial infarction, also known as heart attack. In those who survive a myocardial infarction, and more than half do, the damaged part of the myocardium will not regrow or repair itself. Instead, scar tissue forms. Therefore, the tissue is less elastic than healthy tissue, so the heart is less able to pump blood efficiently. A stroke is damage to the brain resulting from lack of oxygen. This is the 3rd most frequent cause of death in the U.S., accounting for approximately 10% of all deaths. Atherosclerosis, most common cause, and arteriosclerosis can also affect arteries that serve the head and neck, thereby restricting blood supply to the brain. There are also other causes. A stroke damages neurons in the brain. These neurons have no capacity to replace themselves, although healthy neural tissue can compensate. Aspirin can reduce risk by preventing coagulation. Following a stroke, even a few weeks of aspirin use can decrease risk by as much as a third. Research in 2012 with Finnish men showed lycopene was linked with lower risk as well. Inherent risk factors result from genetic or physical conditions that cannot be changed. But high-risk individuals can reduce their risk profile via behavioral management and adjustment in lifestyle. Some inherent risk factors are advancing age, the primary risk factor of cardiovascular disease, as well as for cancer and other diseases. Diabetes. Those with type 1 diabetes are more likely to die of heart disease than those whose sugar metabolism is normal. Family history. More likely to have a heart attack if your parent had one. Sex. Males are more likely to develop coronary heart disease prematurely. Although the onset of coronary heart disease is typically 15 years later in women, more women die of heart disease than men do. Most research has focused on men. Women seem to be protected at young ages from CHD relative to men. A possible reason is that higher HDL levels appear to be linked to premenopausal women's higher levels of estrogen. Women experience higher risk after menopause. Weight gain may partially explain the risk. It was thought that hormone replacement therapy, HRT, would decrease rates of CHD among women, but it may actually increase risk. Therefore, the relation between estrogen and heart disease remains unclear. Estrogen levels probably only play a small role because they are larger sex discrepancies in some countries, and the gender gap was small until the 1920s. There is a gender discrepancy with regard to treatment. Avinian and Epstein in 1991 found differences in the use of diagnostic and therapeutic procedures between men and women hospitalized for heart disease. Women did not receive the same aggressive treatment. Steinhardt in 1991 found that although female patients were as likely as male patients to have had angina and to have experienced more disability from angina, they were only about half as likely to undergo cardiac catheterization and to receive bypass surgery. CHD is diagnosed earlier in men and treated more aggressively. Finally, ethnic background. African Americans have nearly a twofold risk for cardiovascular deaths compared to European Americans. The strongest risks are high blood pressure, low income, low education level, and greater cardiac reactivity.